So the interactive session, question and answer session for the day 1 of the certification in spinal manual therapy CSMT, which began here at AOMPT Center for Manual Therapy Education and Training at Bangalore. We had day 1 of explanations and demonstrations related to upper cervical spine and lower cervical spine physical examination, and how to extend the history and subjective examination and interrelate palpation with the movement testing and also the manual examination procedures. Okay. What we are actually saying is the principles and the pro forma when we are doing the physical examination, the way which we can even advance the physical examination through differentiation based movement testing or through orthomyoneuro manual therapy. Okay. So opening this session for the questions for the participants who are attending the whole day live. Okay. And so they are with us. So over to Dr. Ritu ma'am. Yes, ma'am. You have any questions?
Yes, sir. I have one question. Sir, one of my patient whom I am treating from last 15 days, his neck is completely blocked, not extension, not flexion, not rotation, no movement was there. But after I had started manual therapy, MFR and MET, now that upper cervical region, he is getting 30% movement is coming, start coming. Means now his neck is like this, this and this started. But for his better recovery and a better movement, I want your suggestion. How can I give him a best therapy that he can see like back? He want to turn when he want to see back. He want to turn completely. So I want your some advice and some another method which I can give him.
Have you screened for any instabilities in upper cervical spine?
Yes, sir.
Have you ruled out vertebrobasilar or the transverse ligament instabilities? Then you can try. Yeah.
I checked, sir.
You checked both negative.
Yes.
Okay. Then you can use combined positions and movements. Okay. When individually you are not getting the range beyond 50 degrees. Okay. Individually also atlas has to be mobilized. Axis can be mobilized. Okay. So you can use the same techniques of post-anterior pressure or the medial glide, okay, to the atlas, because the positional assessments, okay, atlas, axis and occiput, upper cervical spine positional assessment, okay, and related with the movement assessment, okay, either individual or combination, okay, which we were seeing today, and see if which of the combination is more exactly reproducing the patient's symptom. Individual movement is restricted, mobilize the individual movements. In that you can give grade 3 mobilizations, okay, where you can give to the atlas and the axis. Once the range responding and it is improving, functionally is better, then immediately add on with the deep cervical short flexors, because every range improvement when you are getting that range, the stabilizers has to work. Okay, so motor control 1, and then further go to combined positions and mobilizations. Okay, as a progression. Yeah. When you are actually having a difficulty, simplest upper cervical rotation restricted. Okay, if chin is inside and then this much restricted, immediately stabilize the axis, give the distraction. Okay, with the arm, forearm, and then giving the distraction. When you are giving the distraction, you can rotate. Okay, with the distraction, you can rotate so that the capsule will get stretched, the facet joint capsules, and after which patient, yeah, movement is free. Okay, all the movements are restricted. You have to find out which movement is more restricted than the other. Okay, you cannot tell all are equal. Okay, never. One will be restricted definitely, and right from beginning, some movement would have been restricted. Now recently, other movements got restricted. The recent ones which are restricted don't emphasize on treatment. Which was there right from before that you treat. Okay. So if initially bending forward was restricted, because patients never notice upper cervical spine movements. They only notice lower cervical. Okay. And they likely to tell the lower cervical positions are the movements, but they won't tell about upper cervical. And another thing is flexion rotation test. The screening one is there. So that you have to do to see whether upper cervical spine is a problem or not. Okay. If both sides is equally range of motion is there, and it is not at all reproducing the patient's pain or the stiff sensation, then upper cervical spine, there is no point in treating, even if range limitation is there. Okay. So remember that functionally it should be there represented, and symptom it should be reproduced. Then only you treat the upper cervical spine. People will have restriction of upper cervical spine, and otherwise also because of developmental anomalies, for example. Okay, so you don't have movements there. Okay, so there is a lot of factors. Direction dependent, right side more than the left, and symptom is right side. Okay, and right side is restricted. You have the flexion rotation right side, which is positive. Okay, and you have the right side atlas is prominent. Okay, so this everything fits. Then you give manual therapy. It will be the magic bullet. Okay, that patient will tell after that it's like wow. Otherwise, myofascial treatments will help, but they're only superficial. Okay, actually the articular problem has to be managed with articular techniques. Okay, and when you are expecting chronic problem, always AM and MT will come in picture. Okay, arthromyoneuromal, where you are giving mobilization force, contract the muscle also, or stretch the fascia also, give the mobilization force, and in the slump test position or in the passive neck flexion test position. Okay. So if you are suspecting that if the combined testing reproduces the patient's, okay, so that's where you can explore further. Rule out giddiness, vertigo. If vertigo is present, definitely your differentiation of vertigo goes into vertebrobasilar vertigo, benign paroxysmal positional vertigo, okay, visual vertigo, and also cervical vertigo. Okay, cervical vertigo, no problem. Treat the cervical spine, vertigo disappears. Okay. I hope he does not have any kind of giddiness, headache, nausea, vomiting. Okay.
No, sir.
So you can rule out intracranial also and vertigo also. Yeah.
Right, sir. Thank you, sir.
Yes. Dr. Paramita, do you have any questions?
Good evening, sir, and good evening, Ritu ma'am. The session was full of knowledge and information that has cramped up in my brain. Then I feel that I have so many questions, but I sometimes I feel that I have no questions also.
Yeah, we can feel anything. Yeah, but what is important is when you have queries, you see which is most important query. Okay, most important question. You can definitely ask that. Okay, and every question it shows that your thinking process. You have more questions, that means more the thinking process is there. And for more questions, we'll explore clinically also more on the patients. Yeah. So it's always welcome. So tell your questions, we'll decide which one to answer. Yeah.
Suppose we are examining the upper cervical region, but the patient is also having the upper cross.
I'm not able to hear you. Just hold on, hold on. Just very less voice it is, too less. Is it your real actual voice? Very soft? Talk like a lecture. Talk like you are taking a selfie video about AOMPT. Now it's not audible. Totally not audible. Dr. Paramita. Yes. Now?
Now it is audible.
Perfect.
Okay. Suppose the patient is having the upper cervical problems and is coming with the less endurance of the cervical flexors, so it's exhibiting the cross syndrome also. So will I start examining from the upper cervical region and then go to the lower cervical and then go to the thoracic rotation, what we have learned in the last phase? So how will I do the differentiation between what is more important in that patient?
If I am doing upper cervical rotation, lower cervical counter rotation, and thorax counter rotation. Okay?
Okay.
You're seeing A, B, C, three segments are there. Okay? This is A, B, C sequence I showed. Other is C, B, A. Reverse sequence. You are adding the movement proximal to distal, you are adding the movement from distal to proximal. Okay? You are adding the movement again, middle also. First lower cervical rotation. Okay? Lower cervical rotation to the left, upper cervical rotation to the right. Okay? Lower cervical rotation to the left, upper cervical rotation to the right, and thoracic rotation to the right. Okay? One is right, another is right, in between is left. Okay? So we can add this in a different sequence and see that which position is added first. I add upper cervical right rotation, lower cervical left rotation, okay, and thoracic right rotation, okay. Then the patient symptom is coming best.
Yes.
That means the cause is upper cervical, okay, because first added, that is producing the symptoms, okay. Cause means not the tissue damage, the dysfunction, okay, the abnormal position, what is there. So you have to treat the upper cervical there. The same way, if I am adding thorax rotation right, okay, lower cervical left, upper cervical right. Okay, in this, if I am getting the best symptom, headache, for example, cause is thorax. Because thorax I added first. Okay.
So we have to break up the movements according to means what the patient symptom is arising at first. At first, what is the symptom is arising, that we have to address first, and then we have
Not
to go
symptom, not exactly symptom. See, for example, if three people are there, okay,
Yeah.
three of us are there. All of us are working in same office. Okay, Ritu ma'am wants leave. Okay, she is telling that I want leave. I want leave. Okay, tomorrow is Valentine's Day. I have to go with my husband. Okay, so she is telling that she wants leave. She wants leave. Actually, tomorrow is working. Okay, why she is telling that she wants leave? She is producing the symptom problem, but the cause is we both are not working. We are not adjusting with her. We are not telling her that if you have to go early, you go, no problem, we'll manage the work. If we both segments are working properly, the third segment will not become symptomatic. Okay? If among both, I am the most laziest. Okay? I don't do any kind of work, only giving lecture. Okay? No work. Okay? Then what will happen? You will be next loaded. I am the cause because I am lazy, I am stiff. Okay? You become hypermobile. You may not become symptomatic because you are adapted. You are used to working more. Okay? You may not become symptomatic. But the next region, when the next segment comes, it is getting the alternative abnormal forces because you are working too much. People are telling that she is not working. Okay? Then what happens? She feels that after doing work also people are not telling that I am working. They are telling me I am not working. So she becomes symptomatic. That I want leave. Better take leave. Understood? So same way upper cervical is stiff, lower cervical is hypermobile, upper thoracic will become symptomatic. Okay? During upper limb activity. Not the neck or the upper cervical. Okay? If thorax is stiff, Then lower cervical is hypermobile, upper cervical becomes stiff, then headache comes. Okay? Headache might come in the upper cervical spine. Upper cervical test will be positive, but the dysfunction will be there in the thorax. What is the dysfunction? Which is kinetically linked. Okay? As I was showing, the compensation I was showing, opposite directions. It can be sometimes the same direction. If it is to do with ankylosing spondylitis or rheumatoid arthritis, like connective tissue disorders, then all the deformities, thoracic rotation also will be right, lower cervical also will be right, upper cervical also will be towards the right. Okay, all are in the same direction. All three we are on strike. We took mass bunking. Okay, like that. Compensation is alteration. One segment is hypo, other is hyper. One is towards the right, another is towards the left. Okay, that is compensation. Both are possible in regional interdependence. The last region is symptomatic, but the cause is first region. First region, you can find a shortcut is past symptom of upper back pain. Okay, so it is gone now. No upper back pain. Now I am having headache. You can suspect the thorax. You should rule the thorax. Okay. Otherwise, if lower cervical movement or position is causing headache, I am reading. After that, I am getting headache. Okay. Two things are there in this. One is visual, because if vision is improper, headache will come. Okay. Another is the lower cervical position is causing the upper cervical symptom. So screen the lower cervical. Your differentiation will go to adding the lower cervical first and then adding the upper cervical. Okay. So that sequence of movement testing will come. Yeah. Any more questions, Dr. Paramita? Yeah. See, questions has to come. It is not that you have done all the courses during the lockdown or you have got all the videos. Both of you are MCMT, you are OCOMT, okay? You have completed that certification orthopedic manual therapy online also and mastery certification manual therapy, both from the AOMPT. So, but when you are applying that on patients, you will get more questions definitely. Okay.
Right.
Regional interdependence is a big mystery. Okay. People are not able to find which segment is actually the cause. Okay. And causative, the symptomatic region, cause and the symptom in the same region, I never believe. Okay. I never go by that thing that upper cervical dysfunction patient is having headache. Okay. I always try to see that thorax, clear the thorax first. Okay. And then you go to lower cervical, then you go to upper cervical. I examine that symptomatic region last. Okay. Because symptom region, anyway, it is not going to allow full examination. Patient will have pain and it will limit the examination. So better check the other regions, treat the thorax, thrust manipulation to thorax, mobilize the thorax, thoracic sympathetic slump you give, and patient will feel cervical headache is reduced. Okay, first day. So you have got 50% relief first day. Definitely in 3 days the subject has to become normal. Okay, that's the best actually to see as a holistic model. Okay. And if you want to give to the upper cervical, then you can give cranial base release, myofascial release is there, or you can give direct or trigger point releases, or deep cervical short flexors, endurance. But if you're treating the symptom region with this, patient will feel better, definitely. They will also get 50% relief. But what will happen is, still the residual pain will always be there, as Dr. Ritu was telling. Okay, the residual pain of 15-20%, they will tell still it is there. I am able to manage all my activities, but still it is there. That means you are treating this region, it's fully not getting cured. Okay, so that means we have to go for what is that associated which is causing, whether it's the lower cervical or the thoracic. Don't go like thinking that kyphosis is there, so thorax only problem. No, you have to check the direction. If left rotation upper cervical restricted means whether left rotation of the thorax is restricted. Okay, alternate segments they both are. Okay, so something like that. Clear?
Yes, sir. Thank you, sir. And once again, congratulations, sir.
Sir, I have
Okay.
one
Yeah,
question.
please.
So the patient which Dr. Ritu was telling about, so I would suspect first the muscle spasm is coming, and that's where the restriction was there in all the directions. So I will do the reciprocal inhibition for excluding the muscle spasm, and then I will go for compression of the facet joints and see whether it is actually reproducing from the facet problems or not, and then I will come down to the articular the compression and distraction. If these symptoms are relieving, then we can find out that what is the exact cause of why the movement is not coming in that patient. Is it correct or not? My
No,
approach is
sir. Yes, absolutely right. Yeah. Okay. That is the same which I told that without checking compression, I said that you check relief of symptoms with distraction. Okay. And then you can again further rotate. Spasm, why I did not think is because she has mentioned that already she has given myofascial techniques. She has used reciprocal inhibition, she has used post-isometric relaxations as a stage-wise progression. And she was clearly mentioning like restriction of the joint movement. Okay, so articularly. So then I started my explanation with the articular focus. Okay. Otherwise, spasm will restrict, but spasm will restrict the active movement. Okay, predominantly in all the directions. And again, spasm is so obvious. When someone does it, they keep holding, okay, and they don't allow any kind of movement. Then you do the reciprocal inhibition. After that, they return, okay, like that. So that is also another differential thinking process. Okay, myofascial and then articular. That's what myofascial she has completed. She told that I have given all the myofascial treatments and still the range is not improving. And around 40% only range has improved, but not much more than that. So what else I can do? Okay, then we went to articular. Okay. So individual then combined whether the movement restriction in one direction is more than the other, you can combine with the mobilization with movements. So various options. Okay. I never advise thrust for the upper cervical, especially when range restriction is there in multiple directions. Okay. When it's only in one direction, where extension, lateral flexion, and rotation to opposite side, okay, the posterior quadrant. Upper cervical is type 1 mechanics. So you need an extension, right lateral flexion, and left rotation restriction. So right side you can give thrust. Okay. If other factors, everything is ruled out, including osteoporosis, anticoagulant drugs, okay, and steroid intake is not there, okay, connective tissue disorders, ligament instability, VBI, everything ruled out. Definitely, you can try that thrust, but that is in only one direction. But it's all the directions. So better give articular based
okay.
assessment and prescriptions.
Actually, sir, I wanted to call him today for the demonstration session, but time schedule I was not confirmed. So he's a software engineer, so he was not able to attend at any time. Na? Otherwise, I wanted to call him and I want to demonstrate in front of you what type of.
Okay. It's possible maybe tomorrow 9 a.m.
Sir, it's too early, 9 a.m. Tomorrow is a
You just
Sunday.
see if the patient can come.
I will talk
Which
to
one?
him, sir. I will talk to him.
Because what is important here is tomorrow the model will come here at 10 a.m. Okay, so we start
Okay.
the session at 10. Okay, so 9 to 10 definitely we can discuss if the patient can come. Okay,
Okay.
or you want to, yeah, it's like a teleconsultation plus a case-based discussion or practical review. Okay,
Okay.
so that way. So
I
what
will.
I would actually do in my situation is, first of all, I take a subjective examination. Then I tell that it is like probably whether it is thorax or lower cervical or it is upper cervical. Okay. After which then the testing goes according to the proforma. Okay. And thorax is anyway tomorrow morning session is there. Okay. So that's the situation. Yeah. Sunday, I think they can come, but most probably
Sir,
getting up early and then getting ready and coming here is a little bit their thing. Okay.
sir, he is working in IBM in a night shift now. That's why it is not possible for him to come so early.
Or after the night shift, straight he has to come. Okay, whichever is possible. Just see. Okay.
Okay. Okay.
Any more questions?
From my
Okay.
side, nothing. You can ask to ma'am.
One participant actually he had registered for the online, but he said that he'll come to the center. Okay, he's in Bangalore only. I was expecting that that participant will come here. Okay, because other than model, if there is one more person who's here, then definitely it's better for the camera movements. Okay, and rather than fixing the camera in multiple sides, and I am only adjusting the camera positions. So that way. Tomorrow I'll try to call another person so that the student can come and they can move the camera better. Okay. And so that we have the continuity like as we are directly observing. But remember when you are attending a direct workshop also, minimum 20 candidates, they all watch. Centrally there is demonstration that is going on. Only one place you will be standing. You cannot see what is happening in the other side. Okay. You can't move and see every time. You will be circling only in the direct workshop. Okay. What I used to do when I take a direct workshop, usually in subjects are attending means I'll make them to sit in a circle. I do demonstration in the center rather than keeping people behind and in the front. Okay. And I perform one this side, another time the other side. Okay.
Yes.
So that these people can see what is happening, those people can see it they are happening. Okay. Because participants very few, they actually move around to see multiple directions. And before you move, the technique is over. Okay. So that will always happen. Okay. And if you are concentrating on moving where I can stand to best view, you will miss the points what the instructor is talking. Okay. So a lot of things will happen and finally you will be nowhere. And your face question mark will be there. And seeing that the resource person will feel what is going on, why is she moving around here and there and she's confused. So always remember that accessibility issues are there both virtually and also in direct also. Okay? When you are attending workshops. What is important is when I tell facet joint, when I am telling the cervical spine area, prominence, okay? And after that I tell you are keeping on the right side. You don't know the right hand where it is there. Okay, but you should know that it must be there only. Okay, so that's the area which I have shown, and you know where to palpate. So when I am keeping that there only, you need not see my hand there. Okay, because it's impossible for the eyes, human eyes, to see all the sides unless I keep a mirror here. Okay, and then the camera is there, then you can see the hand placement all the sides. Okay, or I keep the camera below the plinth. Okay, so that I am holding like this, you can see my finger placements. Okay, so that's something which is very and participant can never go below the resource person to see where the hand is. Okay, so what is important is we are having a visualization. Okay, we are having a visualization as a combination of self-experience, okay, facet joint, and then after that you are palpating this facet joint, yes, on a subject if they are present beside you. And then next you see that, yes, the movement is happening. Fingers are on the facet joint. Okay, he's doing the lateral flexion, fingers are on the facet joint. What happens in the movement? Same side bending, facet joint becomes prominent. Okay, opposite side bending, facet joint becomes flat. Okay, so that thing, when you do this, you are finding that, okay, rotation also, same side it becomes prominent. So that way, and keeping this same landmarks, here you are feeling the facet joint and keeping it. So that way we have to integrate. Okay. And sometimes in learning, okay, what happens is there is a flow, learning is a flow of thought. Okay. But we should not allow the block. Okay. Like something I am not able to see. Okay. We think like that, then what you are able to see, you will miss. Okay, at that moment itself. Although I am repeating enough number of times, but still you will feel that I exactly don't know where to keep my fingers. Okay, because I don't know, I have not seen where the fingers are. Okay, so I am not sure. So like that, the chain reaction of thoughts will come. Okay, so that's why sometimes we need to keep moving. Okay, as you move, even the block also will get released. Okay, it's like block is there, so block is there, it has to slow down, or keep moving, then the block will go. Okay, so both ways you have to think which is the solution. Slowing down is going to affect the continuity of the learning. Okay, and at the same time, something very obvious. I am only standing like this, and I am doing on the subject. Okay, you are not able to see anything. Okay, and the camera is there. Definitely, obviously, nothing can be made out. Even traditionally, expert manual therapist, without mentioning the name, is now not alive. Okay, is a professor emeritus like that. He is first manual therapist in India. He used to initially teach people manual therapy by putting a blanket above the patient, blanket. Under the blanket, hand will be there and he'll be doing the mobilization. Okay? Everybody used to watch, look at him, feel that, oh, some techniques I was using. Blanket is there. Why blanket? Privacy, patient privacy. Okay? And ultimately, those are the instructors who told that on patients directly I am teaching. Okay? But what is the teaching? Okay? Where nothing can be visible. The part itself and the hand. What technique is giving, whether it's on spinous process or facet joint, no idea. Okay? So which direction is giving, no idea. But still people used to learn. This was traditional. Okay? And then it evolved to practicing more on the subjects. Okay? For the best experience, as you said, case discussions, decision making, that is important as part of physical examination. Okay? And real example, how we can relate this knowledge. Okay, so that's important, applied aspects. And the next part is directly having a model and simultaneously doing it. Okay, virtually. Like for example, I am performing a technique. Then immediately after that, you perform all that 5-6 techniques and see the sequence. Or I'm giving you now the access, okay, to the videos, for example. So you see the video, then practice. Again, you pause it. Then again, see the video, then practice. Integrate different palpation technique with the movement testing. Okay. So we are getting a picture. Picture may not be 100%. Okay. But sometimes the dots have to be connected by our own intuition. Okay. We cannot think that every dot will get connected and the picture will be complete. Okay. And there are limitations of everything. Okay. But that should not limit you from learning. Okay. So that should be connected. Okay. That clear? Yes. Do we have any more questions?
No, sir.
Dr. Paramita is so happy to again see me on Zoom. Same like Dr. Ritu also. Okay. It is like
Yes,
almost
I'm
like
good.
1.5 to 2 months and total hibernation. Okay. The winter cold season, all of you have Delhi especially. Yeah.
So chilled.
But still, here again, I am still facing the issue of who's going to be the model. Okay. So I still have to find out some sincere student who can really come. Okay. And be part of this. Okay, if 2 students I get, it's solved, and the visual access can be as much better. A studious student who is an active learner will know which position is best visible and they'll move the camera. Okay? Otherwise, the other student will tell, adjust the camera and sit down. Okay, there's a camera stand, so keep the camera in that and stand, sit. Okay. Model especially, you need to be the highest level of student, okay, to experience the technique on yourself being a model. And a teacher who becomes the model, okay, that asking the subjects to perform on the teacher, okay, in the workshop is the highest level of teaching. Okay. So this is what I always believe, and I always do that in direct workshops. Okay. Today's session, if you see the CSMT, we have the participants who are exclusively registered only online. Okay, so they are all through the online mode for multiple reasons. Because vaccination now only started, so they don't want to travel and they don't want to take risks. One who is in Bangalore is working in a clinical setup, is not got the leaves. Okay, Saturday, Sunday is also in hospital, and still he do not want to miss the course, so he's taking the online option. So it's fine as long as people learn and stay connected, because it's lifelong learning. Okay, it's always there. But resources, everything you will see, there will be a difference. Okay, when you see physical examination videos of cervical spine, rarely I explain the regional interdependence. Okay, rarely differentiation based manual therapy is there or AMNMT is there in physical examination video. Okay, so in between the differentiation based manual therapy came, so it is integrated. AMNMT, then it is integrated. Okay, Edwards concept, combined movements, so there it comes. Maitland concept comes in passive movement examination. So everything comes then and there. Okay, when you do the nags for the thorax or reverse nags for the lower cervical spine, Mulligan's comes. Okay, so always it's a parallel process. Okay, the bricks are there. Okay, don't think that it is perfect. Okay, there are always out of alignment. Okay, some bricks are half, some are full, some gaps will be there. The bricks will be kept later on. Okay, but still for us, wall is a wall. Okay, so that is how we have to utilize our knowledge. Okay? Not like it is like huge gaps are there. You don't know anything. Still you think that yeah I know. Okay, that is cheating yourself. But when you know things and there are things which you have to learn, definitely you keep moving on. Doing itself will make you to learn. Okay, experiential learning. Okay, rather than learning and then doing. Okay, don't be negative critic to think that I should learn, then only I can do. Okay, doing and learning. When you have a safe thinking process, trust manipulation only. Learning and doing is important. Okay, all other manual therapy techniques, doing and learning is always possible. Okay, so wish you good luck. Nice to see both of you here on the screen. Enjoy your weekend. Spend your lovable time with your family and stay smiling.
We are still with our family, sir.
Mm.
You are also our